We're going to keep things moving here. Maybe we're not a Swiss watch, but a tightly wound watch nonetheless with our schedule here today. So I just want to make sure, guys, I do in fact have your permission to have a little conversation today about how trauma-informed care relates to motivational interviewing. I think we're talking about this idea of connecting with people, helping them influence changes in their lives, overcoming some of the obstacles related to their health care that they're facing. And I think to really connect with that, it's especially helpful to remind ourselves, especially with the environment of CareOregon, who a lot of our members are and why this kind of approach can be particularly impactful with connecting with them and being effective. So we're just going to do a little bit of a background on trauma-informed care to some degree. How many folks in here, and I'm guessing a lot of you guys, are already familiar with the concept of the ACE study? A little more than half, I'd say. Adverse Childhood Experiences study is the ACE study. It's a real building block of a lot of the things that we talk about when it comes to trauma-informed care. This was a study that Kaiser pioneered of over 17,000 members. And they weren't just necessarily Medicare, Medicaid type members. This is across the gamut of their entire member population, full cross-section. And what they wanted to prove is that there was an association between maltreatment in childhood, trauma experience in childhood, and later well-being and health in adult life. And these findings showed that there's a lot of these common experiences that are huge risk factors that don't just lead to illness, but that also point down the road towards early death, and that this trauma is a lot more prevalent than anyone had managed to guess beforehand. So this is only about 15 years old, this study. It's comparatively new. But man, it's changed the way we do business in healthcare to a major, major way. So what are some of these questions like? This is just a snapshot of some of these simple questions to give you an idea of what we're looking to dive into with this study, okay? Before your 18th birthday, was a biological parent ever lost to you through divorce, abandonment, or other reason? That, a lot of times we hear trauma, we assume it's going to be some kind of physical trauma. I think we're conditioned to think that. But losing a parent, that's a very traumatic event. Was your mother or stepmother very often pushed, grabbed, slapped, or had something thrown at her? So not just trauma that you experience, but trauma that those loved ones that are near to you experienced as well. Ever hit over at least a few minutes or threatened with a gun or a knife? A little bit more immediate and violent type of trauma, and things as perceptually innocuous as being insulted or sworn at or put down, or just the feeling that maybe you were going to get hurt, those type of things. They ended up finding out that of those 17,000 participants, over 60% of them had at least one category of what happened, and about a fifth experienced 3 or more categories of trauma. Take a look at those numbers in terms of physical abuse, emotional neglect, being treated violently, household members in prison. 21% experience some kind of sexual abuse. So those numbers, pretty sobering stuff. And the more categories of experiences that somebody is exposed to in childhood, the greater their later likelihood of them experiencing these type of healthcare scenarios in their life. Everything from having unintended pregnancies, to smoking, to obesity, to heart disease, fetal death, COPD, depression, alcoholism, intimate partner violence. So the more of those things that you were exposed to in those questions in childhood, the more likelihood is that somehow that road is slanted at a really dramatic downhill angle where you're going to end up running into these situations. And that's the reality that a lot of our members experience. That's the point of origin where they come from, a lot of times when we run to meet them. So again, trauma in this definition here is defined as an event that's really upsetting and your internal resources overwhelmed. There is just too much water in the pot on the stove. What's going to happen when the heat goes up? So that's what we're talking about when we're talking about trauma. There are two different kind of sides of the trauma coin, if you will, in terms of how we look at trauma. There's personal and private experiences, and there are the more public experiences. So public trauma, a lot of people I know in my family, they were in New York during 9/11. That's a very public trauma, a very natural disaster that people were exposed to. Anyone who's had a loved one that served overseas, or if you yourself were in a war environment, or if you were in a community violence situation, riots, those are very public types of trauma. Less talked about, though, are the more personal and private types. Domestic violence, sexual assault, things like that. And those more personal types of violence tend to be the ones that resonate and cause the deeper wounds for folks. And they kind of short circuit your ability to trust somebody, which I don't think is a theory that we need much help proving. If somebody betrays your trust, short circuits your attachment as a child, you end up thinking that it's more deliberate. It's not like, oh, I happened to be in Los Angeles when there was an earthquake. Okay, that's just, you kind of write that off as an act of God, right? But if you experience one of those fundamental types of traumatic events as a child, you feel like that was a deliberate, intentional act. And I think that's why those are a lot more upsetting. So with trauma-informed insight, we know that the patient is kind of overstimulated in this near constant fight or flight state as a result of their experiences. They have a very, very low triggering threshold for what's going to set them off. How many of you have dealt with members or patients that's sounding a little familiar? Absolutely. Absolutely. And so for folks like that, if you're in that fight or flight mode, if I'm overstimulating you and you're feeling like you want to run out the door, do you think that you're going to remember anything I talked to you about when you're in that situation? Will you retain any information? If someone's giving you some instructions about how to maybe use your insulin, you think you're going to remember that? And that's a lot of times what we run into is if you go into the environment, okay, remember a lot of our members are homeless. They've been through very challenging circumstances. Health literacy, regular, normal literacy in our population, super low, super low. Very challenging for these people. And you go into a doctor's office, you go into a pharmacy, and everyone's perceived education level is incredibly high. There's all these diplomas and certifications on the walls. It can be a very intimidating place, and a lot of times people just want to get the heck out because it's an intimidating environment to be in there. So your alarm system isn't working the way it normally should. You may want to avoid stuff profoundly, and you probably find it very difficult to trust other people. I think that's the key thing here, and one of the reasons that MI technique, that politeness, asking permission to get the glass of water thing is so important because it helps establish trust. So definitely a good deal. That whole accelerated fight or flight thing, it's a phrase you'll hear referred to very often as hyper-arousal. I see a lot of folks in the downtown environment where we work here that are in a state of hyper-arousal, who I am sure experience some degree of that, where things that happened in the past kind of haunt you. We talk a lot about, when we're talking about things like our meds chart or doing med reconciliations, assumptions we make about what's the most important medications to people. We're saying, oh, it must be their hypertension medication, or it must be their diabetes medication. Those must be their most important medications. Anyone here know a medication called Prazosin? Yeah. What does that stop? Yeah, it stops nightmares from happening, right? And we run into a lot of folks who, for them, that's my most important medication. I don't want to have those nightmares come back, because there you are. It's those things out of the past, those memories that come back to haunt you, that you want to avoid re-experiencing those at all cost. So here's kind of how I think how it feels typically for a lot of our members going into a medical office. I think, you know, they don't really feel like they're on an even footing. Super intimidated by that big dog. I think that's a lot of times, that's how it feels. Motivational interviewing, about looking through things from the eyes of the person you're trying to help. See their way. Get a sense of empathy for what they're going through. And I think this is a group of people that really need to have that put front and center in terms of the perspective in which we interact with them. So we want it to be more like this. What kind of conversation at the very beginning did we say motivational interviewing was? Where the two people are working together. Collaborative, exactly. So it's a collaboration. So you're more on even footing, where there's not that elevated authority figure looking down and dispensing pearls of wisdom. So we talked a lot in terms of the first two segments that we had this morning about what's good to do, what's effective to do. I think it's also really important to keep in mind what's not effective to do. And this ties back to that putting your superpower in check that we talked about. That phrase equipoise that is a little new there. It's you want to avoid the over-assessing. Because if you're meeting somebody for the first time and they're hitting you with a barrage of questions, just rattle-da-da-da-da, is that off-putting? If my fight or flight mechanism is in hyper-arousal, do you think that's going to want to make me be more comfortable and stay in the room if I'm getting 1,000 questions, or am I going to want to head for the hills? Probably head for the hills. It's important to be able to create engagement at the beginning. And as we saw illustrated pretty clearly during that first little exercise we did there, you want to avoid telling people and making a quick, pulling out your solution from your quiver of solution arrows that you carry with you all the time. Certainly you recognize common situations all the time, and you're like, I know what works here. I know what this person needs. And again, it's just a good thing to reinforce is checking that impulse where you don't necessarily throw that at them. And it can be with these folks, very often it works against engagement at the beginning. There's a reason that a lot of times I'll recommend things like, asking about the weather, how you doing, keeping things personal before we start getting into it. It's like dating or whatever, you're kind of starting to build a relationship. You're making the other person be at ease before you're getting to any kind of an agenda. You're making sure that we are seeing each other and understanding each other. Useful stuff. So it's again, and there's a handout where we've made a little guidebook of things to avoid. Most of this stuff is in there, so you kind of refer to it if you're going to sit down and maybe start doing a little MI with session with somebody. Just kind of have a look at those things, just to kind of reset your goggles before you start with somebody. Go, you know what, let's just kind of remember, let's not ask a bunch of questions out there, because the thing we want to avoid is that whole power differential that gets in the way of engagement. It's like there's a lot of people that intimidate me, and I want to make sure that if I'm going to be working on something, that we're ideally working together as equals. I don't want this to be haunting me in the back of my mind again, where I feel like, okay, I'm just not on even footing here, so probably my contributions won't matter as much. So it's just always a good idea to recognize that and strive for the more equal footing. So I just think that background about our audience, I think, does it seem like a reasonable thing to postulate that this kind of communication style maybe will put them at ease and make it a little easier to connect? Because MI is all about the other person talking more, right? They're getting a chance to express themselves. Do you think that a lot of the people that we just talked about that came from a background of trauma, maybe folks that have been homeless for a long time, are they used to having their voices be heard? A lot of times not. A lot of times they're marginalized people. They have not been asked what they feel and what their opinions are. They've been told a lot, and they've been dismissed a lot. And I think it's one of the reasons MI is so effective. I've been lucky enough this last year to spend some time with some of our pharmacists out at the clinics, watching them do these comprehensive medication reviews, we like to call them, and we're really trying to kind of change that dynamic a lot. So comprehensive medication review kind of sounds like, oh God, I'm going to go have to see my accountant, right? He's going to ask me a lot of questions. I'm probably not going to be very comfortable during that. And the dynamic now is really different. I see a lot of people practicing, especially when they're using something like the MEDS chart in there, because there are less metrics, less Excel checkboxes, and more asking questions about how you feel about these meds are working for you. How do you actually feel about that? And it's really interesting, being a fly on the wall during those reviews, to watch how the patients respond. 90% of the time, without even being asked, the person would say, wow, no one's ever asked me what I think before. I never really asked how I feel about my medications. And you kind of hear that kind of loosening of the cork coming out of the bottle. And as they continue to ask more questions about their medications and their effectiveness, the person starts talking. And they've had a lot of feelings and thoughts that have been kept inside there. They just haven't been given permission to let them out. And they want to engage and talk about them. And usually there's frustrations and obstacles and all kinds of issues that they're dealing with that they've just been looking for somebody to say, let's talk. And those two words are just super powerful. And I just think that's why in the environments we're dealing with these folks that we're trying so desperately, who need our help the most, that's why this MI is, to me, a pretty fabulous tool. So we talked about the 4 pieces in our toolbox that are the ORS background, the little pieces that we have to work with. Let's go back and look at MI from a process perspective, because as we saw early on, that little wheel we had from pre-contemplation through maintenance through relapses changes a process, right? It's a cycle. We saw the steps. I can't just jump to the top step right away. I gotta work through my stuff to make change happen. And so in MI, there are 4 processes that are good to know about, because usually things will unravel and move along these 4 processes. When you're first starting to meet with somebody, you're creating a relationship. So initially what you're doing is there's engagement. So you're starting to engage. As you get the person talking and you're building rapport, you're starting to get a little closer to the heart of things there. You're focusing. And then you're evoking. Probably one of the most important stages there, and we'll talk about why that is. But evoking then leads to planning, because when you're planning, at that point, then you know, okay, we actually are getting close to the point where this person wants to start making some changes. I heard some planning going on right up here between you two a little while ago. You were planning right away. It was great. So let's look at these individually. Engaging, I don't think we need to spend a huge amount of time on that, but it's basically you're establishing what are the folks impacted by trauma least likely to have? Trust, absolutely. So you want to put a big emphasis on that up front by building a mutually respectful relationship. You got to make a connection. It's worth spending a bunch of time talking about stuff that has nothing to do with where you're going. You know, just so they can feel that they're getting heard as a person. You know, I love that when someone spends time doing that with me. It's an art form, and it's so easy to do, but so seldom practiced. So I think, for me, you can't get to the other places without having good engagement. And it just, boy, it really, I think everyone would agree, puts people at ease. Then you're more likely to open up. So you want to make somebody feel comfortable. You want to have mutual goals. It's the kind of stuff in any kind of service type relationship, if you will. You want to feel like where you're going to go with this person is going to lead to something. But I think with MI, and especially with this connection between people who come from a background of trauma, I think that the most important part of that, I'm guessing if I'm somebody who maybe has a super high ACE score, I'm betting I've probably gone through my life a lot and seldom been understood. I think that I probably, you know, people see me walking down the street. Maybe I've got some behavior issues that manifest themselves visually that people don't get. Maybe I don't look like everyone else. and maybe I'm just dismissed frequently. And very often people may not know that I went through, 4 or 5 years in Iraq or Afghanistan or wherever I was that put me in this place that I am today. People make a book by its cover judgment. In short, I'm not being understood. And that's really what MI is frankly all about, is letting that person feel understood. And when you're understood, you're more likely to be able to articulate what you want, express your values, and move towards change. So after you've built a rapport, then you can start focusing in terms of the change journey that we're going for there. And that's an ongoing process, but basically the two of you are agreeing where we're going. Where we're going. Are we going to start working on taking our vitamins? Are we start working on exercise, changing what it is that we eat and put into our bodies? What are we going to focus on in terms of our goal? The more focused the goal is, probably the more likely that we can achieve it. If I'm working on 10 things at once, chaos. If we're just working on one little thing, I'm betting we can find a way to get there. You want to basically give that person the foundations of what will ultimately, in step 4, be their plan. But Erin talked about watering seeds a little bit, creating those things. With focusing, you're doing a lot of that kind of early groundwork for them. You're kind of setting the stage for the steps towards change that they'll want to be making later on. So you're basically going to do that by talking less, by listening more to what they say, and letting them guide you with whether or not you're on the right path or not. And we'll practice doing that in a couple of minutes. That's going to help you think. So it's really more you just really learning to focus on listening. And once that rapport has been established, and engagement has been created, then you know there's a good chance that person actually will want to talk to you and will be able to open up, and then you're off to the races. So focusing, huge deal, and that's where your ORS skills come into place the most. Probably the gateway, though, where a lot of the stuff happens, where you know you're turning a corner and you're actually making your way around that wheel and climbing up that staircase of change, is when you're working towards all the time finding that person's motivation for change. You're not finding it and saying, here it is, Bob, there's your motivation. They're finding it. And when they find it, that's when that change talk happens. Who can give me a couple of examples of change talk?
Stating a goal, maybe?
Yeah, give me an example.
I'm going to go to the gym at 7:30 in the morning, Monday, Tuesday, Wednesday.
Great. You're going to do that. That's an action. What about like a kind that's more like a desire? I got to do something about my weight. That's a need, right? Yeah, or desire. Desire. Yeah. I wish I could find the time to go to the gym. I need to be not always running late for appointments. All those kind of things. I got to get my high blood pressure under control. I wish I wasn't so overweight. Those are all aspects of change talk. And it's during this evoking stage is where a lot of the change talk happens. So that's why it's good to be able to recognize what that sounds like, because when we hear it, we want to be able to encourage it and keep it going. So we'll practice doing that in a little bit here to see what that feels like. And then planning. Planning's where it's like you've kind of heard the people say, okay, this is what I want to do. Change talk has happened. You're hearing that they really do want to do that, and probably there's going to be some sense of commitment through all that. They're saying, I am going to do this. I can get a pill organizer and some kind of bag for my medications, and I can take my meds every day. I can stop going to McDonald's. I can do that. I'll drive a different way to work where I don't drive by McDonald's. Those kind of things. I can walk up and down the stairs when I first get to work in the morning. Then it's like when you're hearing that, we're on the threshold of where we can make a plan. And ideally, it's a specific plan that that person's not going to think is unreasonable. A good plan ought to feel what? Attainable. It should say, if someone says to me, Paul, I want you By the end of July, I want you to run your first marathon. Am I going to pull that off? Well, not without a lot of pharmaceuticals. But no, that's not reasonable at all. There's no way that's going to happen for me. There's no way. It's not realistic. But if someone said, Paul, I'd like you to be able to maybe see if you could run 5 miles by the end of July. If I work up to that, that seems a little more reasonably. That's a good plan. But how am I going to do it? And like with any kind of good plan, it should be real specific for somebody. I'm sure that you guys, at some point during your work careers, have had some kind of SMART planning goal thrown at you, that lovely acronym we have, or during job interviews. Give me an example using the SMART matrix. Yeah, everybody knows these days that it should be measurable, achievable, relevant, and let's put some time around it. In 30 days' time, let's check in. How's it going with not going to McDonald's? How's it going with the stairs? Let's put some time around that, because if you got a framework, you can probably see the picture a little clearer. So a SMART plan is definitely a good thing. So just to recap, the evolutionary stages here, you're engaging to begin with, laying that foundation so that all the other stuff has some place to stand. You're focusing in on towards what that change that we're desiring to work on actually is. Then we're getting the person to evoke their reasons. We're guiding them using just the same way you saw Erin do here a little while ago, guiding them towards what those motivations are, be it being able to spend more time in the garden, to live longer, whatever those are, but guiding them towards expressing those, evoking those things, and then making a plan. So not too crazy. It's definitely not like IKEA instructions. These are pretty easy plans to follow through with. And what's amazing is I looked at a ton of motivational interviewing stuff when I was first getting started, went to different classes, and I wasn't able to find anything as like, wow, thanks, roadmap, as the template that Erin put together here, because that's great. That's basically, you know, the streamlined, you can't fail by doing it version, because she's got everything positioned there in order of what you could do. It was just without even looking at it, you were able to see her go through her initial question asking, her focusing, then she started doing a lot of reflections. Your garden gives you joy. You love being out there. What did she say? It fuels your soul. You know, that was a reflection that went way deeper than anything I think you literally said, but that was a reflection that really showed that she understood what you were saying. That was awesome. And then I heard summaries happening from Erin, where she was giving us a nice kind of recap of all of those reasons together, showing that, yeah, wow, I was been listening to you this whole time. That was great, just by following that template, and there she went. So you've kind of looked at the toolbox. You've seen the oars. They're not so crazy, right? There's only 4 of them. It's not like those Viking ships where there were 30. I think we can handle 4 different oars. What we want to do at this point now is we want to do something with them. We want to take the chance to just use these simple pieces that we've learned a little bit about our language, and we want to be able to put them into practice. We want to be able to put our oars in the water. So that's what we're going to do during the rest of the time we have here tonight. Enough of the chatting and the talking from us guys. Now it's time for you guys to talk. So what we're going to do with the rest of the time we have over this next hour is we're going to take our time and we're going to have fun with this stuff, okay? And don't get hung up on, is there a right way or a wrong way to do it? This is just an introductory, putting your toe in the water, or a refresher if you've already done some MI. So we have 3 exercises that we're going to go through over the next hour or so here, and then we'll kind of share what we're experiencing at the end of each exercise. So the first thing you guys need to do, I remember we kind of asked everyone to come up with a little list of several things you'd like to change. You don't have to expose anything crazy or too intimate if you don't want to. Though what happens in MEDS Ed stays in MEDS Ed, so you're pretty safe. But it can be anything, the kind of things we've been chatting about that we all share desires about. For me, it would be eating less, wanting to exercise more, keeping my mouth shut more often. Those are the things I really like to work on. So it can be simple things like that. The first thing we need to have you guys do is you've got a list of all these different exercises in your handouts. We're going to go and start in with activity 1. And the first thing you guys need to do is we need you to get together this time in little groups of 3. So I'll give you a couple seconds to go ahead and create some zany trios together. No singing required. Definitely feel free to move your chairs around, do whatever you want to, go crazy. This is your room. We can move things around as much as you want. I don't expect that we'll be video recording this section here too, so you can kind of go nuts.